Hi, are you able to hear me?
Yes, we sure can. Mr. Gutane, just go ahead and start.
Sure, great. Well, it's a real honor for me to be able to do this. I wish I was there in person, but unfortunately couldn't get out of the lab. I'm wearing my scrubs because I have some cases today. But I was just asked to present a little bit on renal denervation, and I hope to be able to take you through an overview of why, how, and where this field is going. So again, it's an honor for me to be here on behalf of all my colleagues here at Columbia and CRF. If you could go to the next slide, please. I have no conflicts relevant to this talk, although I am involved with several of the trials here in the United States. Next slide, I mean. So the scope of this talk first is to just discuss briefly the background and epidemiology of hypertension, discuss the role the sympathetic nervous system plays in hypertension, in specifically patients with resistant hypertension, and then to discuss not only the feasibility of a catheter-based approach, but also the clinical trial data to date in this field, and then where we're going, not only discussing some new devices, but also new applications of renal denervation technology. Go to the next slide, please. So just, as a brief overview, I know we have a mixed audience, but essentially hypertension is not only growing in terms of its scope, but interestingly, despite the fact that we have multiple medications that are efficacious in treating hypertension, there's still a large proportion of patients that are uncontrolled despite treatment. And then there are numerous patients that actually are untreated despite the availability of medications. And that's for a number of reasons relating to both adherence issues as well as availability of adequate medical care. The reason that this is important, go to the next slide, please, is that blood pressure reductions are something that can reduce cardiovascular morbidity and mortality. And this is just a slide that looks at the failure of multi-drug approaches to treat hypertension. And you can see it ranges based upon the country that's being studied. Certainly in the developing world, we see this as even a more burgeoning problem. So this is a global public health issue, the treatment of hypertension as a whole. And despite multiple medications, there are many patients that are not successfully controlled. If you could go to the next slide. So this is just a slide demonstrating among populations the increase in cardiovascular mortality with each increase in blood pressure of 20/10. So on the left of the slide, you can see patients that are well controlled, what their overall mortality risk is based on actuarial tables. But as the blood pressure goes up, you can see there's this sort of dramatic increase in cardiovascular mortality, predominantly relating to heart disease and or stroke. And therefore, prevention of this is an important way of impacting late cardiovascular morbidity and mortality. Next slide. So this is just a slide demonstrating in a population that if you were able to reduce the blood pressure by just 2 millimeters of mercury, you could actually impact a reduction in cardiovascular mortality on the order of 10% in stroke and 7% in ischemic heart disease. Now, this doesn't mean that for an individual patient, a 2 millimeter reduction will do this, but across a sea of patients, so everybody in the auditorium, if you could do this in your practice, it would be impactful from a public health standpoint. Next slide. And this is the reason why hypertension is important. Now, the specific area that's been studied, and this is really important to emphasize it, in terms of the studies thus far on renal denervation, they've really focused largely on a population of patients that are known as resistant hypertension. As interventional cardiologist, I have to confess that I had to go back and read a little bit more about the hypertension literature before I understood this. But essentially, if you take the entire circle of patients that have uncontrolled hypertension, those that are resistant are those that have blood pressures greater than 150 or 160 typically, despite being on 3 medications at maximal doses or maximally tolerated doses. Just an example of that, I was talking to one of the hypertension experts here in the city the other day, and he mentioned to me that when we start titration of ACE inhibitors, as cardiologists, we often will start with, for instance, lisinopril 10 milligrams, then 20, then 30, then 40. When he's treating a patient with resistant hypertension, he doesn't start with any of those doses. He just starts straight with 40 milligrams because that's the dose for treatment of hypertension as opposed to treatment of heart failure. So I think as interventionalists, we have to get ourselves into a slightly different mindset when treating hypertension the way hypertension experts do. So resistant hypertension is despite maximal doses of these medications, one of which has to be a diuretic, you still have a blood pressure typically greater than 150 or 160. Next slide. So, sorry, were you saying something?
No, you're good.
Okay, so go ahead. Oh, that's me. Sorry, I didn't realize that's me that's
Yeah,
echoing.
I think you're getting a feedback. You're coming through loud and clear here. Very good.
Okay, great. So the next issue here relates to how the sympathetic nervous system actually modulates blood pressure. And in fact, when one were to examine the effect of the sympathetic nervous system, you can actually see that it actually interfaces with a whole host of organs, lung, liver, kidney, and regulates a variety of bodily processes in that way. And in general, we all know that the sympathetic nervous system can modulate fight or flight, but specifically it's been demonstrated to modulate blood pressure, particularly in patients with resistant forms of hypertension, as shown in the next slide. So the next slide actually shows you that if you have normal blood pressure, and that's your basal sympathetic activity rate, based upon studies looking at sympathetic nervous activity, you can actually see that with varying forms of hypertension, going from high normal to white coat, all the way over to essential hypertension and more resistant forms of hypertension, sympathetic nervous system activity actually increases. It turns out that this seems to be greater in younger patients compared to older patients, but basically you see an increase overall in sympathetic nervous activity. Next slide. So this is just an example of the age relationship that I mentioned. As you get older and older, where this hypertension may be just due to stiffening arteries, sympathetic nervous activity may be down-modulated to some extent, but particularly in younger individuals with essential hypertension, particularly resistant hypertension, there's a greater rate of noradrenaline spillover as measured by Murray Esler and colleagues and published in 1984. Next slide. So with the recognition of this, back in the 1950s, there were actually surgeons who would do surgical sympathectomy. And so they would go in with an open procedure and perform sympathectomy for patients with very, very difficult to treat hypertension. Now, the problem with this is it was very effective in terms of reducing hypertension, but it was a morbid procedure. And then as medications were devised to treat blood pressure, this surgery went by the wayside. It is interestingly still used occasionally, sympathectomies, particularly for chronic pain syndromes, and has been used effectively for something called chronic loin syndrome or loin pain syndrome, which is a form of autonomic, excess, if you will, from kidney sympathetic activity. But for blood pressure, this has obviously gone by the wayside. Next paragraph, or next slide. So the concept of renal denervation done by an endovascular approach is based upon that fundamental principle that you can interrupt the sympathetic nervous supply to the kidneys. But rather than doing it with an open surgical procedure, because the nerves travel along the arteries, one could actually go up via the renal arteries and interrupt this feedback cycle that goes from the brain down to the kidneys and back up to the brain again. So there are efferent nerves that go from the brain to the kidneys and afferents that go from the kidneys back up to the brain. And by cutting the cycle, next slide, you can actually see that basically you'll be able to reduce the effects of sympathetic nervous activity not only on the kidney, but also as it feeds back to the brain and blood vessels. Next slide. So the reason that this can work from an endovascular approach is because the nerves of the renal arteries, the sympathetic system in particular, travel in the periadventitial space. So this is actually just a schematic diagram demonstrating the relationship between the media and the lumen to the actual adventitial nerves themselves. Next slide. So the question that always comes up is what's the depth of these nerves? Because if you were to devise a device that could treat these nerves from the lumen, you want to make sure that you actually treat the nerves and don't treat the lumen per se. And so this is actually data that was published last year looking at a mean depth of, not that much, approximately 0.5 to 1 millimeter overall, but ranging ranging depending on where you are in the kidney as a whole. Now, you can see there's actually a distribution. There's some nerves that are deeper, there's some nerves that are more superficial, and the distribution varies based upon the proximal, middle, and distal segment of the kidneys. The problem is this study itself is even controversial because this was an anatomic study that was done without perfusion fixation. So in other words, the vessel wasn't pressurized. As a result, the vessel could collapse. When you're looking at distances, they may be closer to the lumen than they might actually appear. And this was actually shown by Renu Vermani at data she presented at TCT on the following slide, where she demonstrated that perhaps these arteries, advance the slide please, the arteries were, or the nerves were a little bit deeper. Next slide. So here you can see that the depth were slightly deeper. So I think that this actually illustrates the point that we need to learn a little bit more about the mechanics of this, because again, if we devise a device based upon the prior study to target nerves at 0.5 to 1, in reality, with perfusion in the vessel, those nerves are further away. We could perhaps be inducing medial and subadventitial damage rather than actually treating. Next slide.
We're losing the mic.
Approach of the simplicity catheter. This was the first technology that was devised. This is a catheter that was built by a company called Ardian that was subsequently acquired by Medtronic. Essentially, it's a very simple procedure. You cannulate the renal artery with a guide, and then in a non-wire-based system, advance this RF ablation catheter and do circumferential burns in a spiral pattern, approximately 2 minutes per burn, 4 burns per artery, and one were to do it bilaterally. Next slide, please. Now, advance. So this is just an example of what it looks like. If you go through, that's the catheter being withdrawn. There's a guide in the renal artery, and the ablations are being done. Next slide. This is an example of what you can get, and there's some attributes of this catheter that are important, and also this would be true if you were using a standard off-the-shelf EVP catheter. Sometimes, as we know, these patients can be having tortuous anatomy, and this is an example of a case that we did where there's a sheath up from the right side, and this is a stiff wire from the left side trying to stabilize things. And you can imagine how difficult it would be to advance a non-wire-based catheter through this sheath blindly into the renal artery to effect a bilateral ablation. Next slide. We were actually able to do this by using a morph catheter, so a deflecting tip catheter that then I used with the wire on the other side for stabilization to get this catheter in and do ablation successfully. But again, with variant anatomy from a femoral-based approach, this can be challenging at times, and that's why there are several companies trying to develop radial-based approaches, because as we know, with the takeoffs of the renal arteries like this, it's often easier to go from above. Next slide. So when you actually do ablations, this is essentially what you see. There's a zone of radiofrequency treatment that you will sort of be able to ablate. And you're only ablating it focally in one slice, if you will, of the cross-sectional area. And down here on the bottom right of the slide is the artery itself, and the nerves that are susceptible in the periadventitial space are shown here with arrows. And so the goal is to target those, but you don't want to go too deep because you can then burn other things like the IPC, et cetera. But again, if you don't burn too deep, you're going to miss these nerves that are in the non-susceptible zone as shown on the top left. Next slide. So what actually happens when we do this? This is actually data presented by Professor Joner and colleagues at TCT, and I actually believe they're now published online in Eurointervention just this week. I haven't looked at the article yet, but I suspect the same things are shown online. On the left is the angiogram, on the middle is OCT images, and on the right are histology. And what you can actually see is there is some damage to the intima and some char formation by OCT right in the middle that happens acutely. The clinical consequences of this are not known but thought to be minimal. But if you then go to the next slide, what actually happens over time is you just get a burn in that distribution, but no actual medial or intimal damage over the follow-up period. Next slide. So here's what you see again acutely. You see some changes in the endothelium, but on the next slide, you actually see that the intima looks okay, there's repair forming, and in the periadventitial space, you actually start seeing nerve degeneration and damage. Next slide. So there's other ways of measuring this. This is actually a marker of neurofilament protein that can demonstrate that acutely and during control patients, you don't see any changes, but over time you start seeing actual death of the nerve bundles themselves. Now, it's interesting, there are some data suggesting that perhaps if you leave the myelin sheath intact, you can actually get regrowth over time. And so therefore, it might be advantageous to have an ablation that not only hits the nerve bundle, but also causes demyelination. And it's unclear to what extent differing technologies will be able to actually impact the myelin sheath itself. But I think this, again, really emphasizes the importance of trying to understand this from a preclinical way so that we can then start determining whether there are differences between devices or more effective ablation techniques and paradigms to use. Next slide. So what actually happens, this is just an example of data from Medtronic in animal testing. This has also been replicated by companies like Boston Scientific and others. And you can actually see that if you have untreated controls, there's a certain amount of norepinephrine that gets released, but actually catheter denervation done bilaterally is actually very similar to surgical denervation in a small series of pigs in terms of reduction in norepinephrine overall. So this does appear to not only cause blood pressure effects, but there's a mechanistic relationship here demonstrated with norepinephrine spillover. Next slide. So this is actually another interesting study I think it's important to mention, where they actually took anesthetized dogs and stimulated the renal nerves. And on the left is shown what happens. So pre-ablation, you actually see a rise in blood pressure with stimulation of the renal nerve. Now, these are dogs who are anesthetized, so presumably you've relieved the pain responsiveness. What they then did is they ablated one side and left the other side intact. And shown here in the middle and the right columns of the slide are what happens when you then stimulate. So on the ablated side, if you then stimulated right away, there was actually no change in blood pressure, but on the non-ablated side, there was actually a change in blood pressure. So this is, again, demonstration of some sort of mechanistic effect of renal denervation, specifically on the nerves in the renal, the renal vasculature. Next slide. So this was also demonstrated in a human. This is the first New England Journal case report, 2009. After successful denervation, blood pressure reduced from 161 over 107 to 141 over 90, with a variety of different other parameters, all going in the same direction, demonstrating that there were not only effects on norepinephrine, but also end organ effects relating to left ventricular mass and also renal plasma flow. Next slide. On the basis of this study, a series of first-in-man studies as well as larger randomized trials were actually initiated. This is the Medtronic Ardian program. I'll also show you data from some other companies as well. Next slide. So in the first study, the Simplicity Hypertension 1 study, next slide, you can actually see this is the change in office blood pressure through 36 months. This is data that's recently been updated. The thing to commit to memory is for these resistant patients, and again, these are patients who start off with blood pressures greater than 160, the reduction in blood pressure on systolic is approximately 30 millimeters of mercury, and with diastolic is approximately 10 millimeters of mercury. Now remember, with all these slides, and I would say this for every company, on the rightmost portion of the slide, these patients have less follow-up. Just look at the numbers at the bottom of the slide. So before we get too anxious or too exuberantly excited about this, it's important to note that in the middle of the slide is where the majority of patients lie. And this data, approximately 30 over 10, does seem to be consistent across other devices as well, and it is generally thought to be the case for patients who start off greater than 160. But for patients who start off at maybe 140 or 150, we would expect a less exuberant response. And again, we wouldn't want to drop those patients by 30 or more because that might actually be dangerous to them if they started getting hypotensive. Next slide. So this is the percentage response rate. And this is an important slide because you'd like to know for a procedure that you're going to do what proportion of patients are actually going to have a reduction in blood pressure. And so as defined as a reduction of 10 millimeters of mercury or more, you can see that the response range ranges from the 70 to 80% range as a whole. Now again, there does appear to perhaps be a trend for increasing rates of responsiveness over time, but I would caution this analysis or this interpretation because again, as shown here in the bottom right, the numbers are small out to beyond 2 years or so. Next slide. So 70 to 80% response rate seems good, but again, if you're a patient undergoing a procedure, that's something that you would want to know, because there's obviously a 3 in 10 chance or 2 in 10 chance that you would have a procedure with absolutely no effects, or a minimal effect, if that. Now, additionally, the other question comes up with safety, because if you're going to have a procedure, is it going to be safe? And so in general, this does appear to be a safe procedure. It's approximately 38 minutes with this device. There can be shorter times with newer iterations of not only this device, but also other devices. And in general, there are no major complications seen aside from groin access complications that one might expect from a standard femoral access procedure. Next slide. So the next trial that was done was a randomized trial, hypertension 2, 106 patients randomized to renal denervation versus control. This was not a sham-controlled trial, but it was a randomized trial. Next slide. In this trial, at 6 months, for patients that were randomized to control, they were allowed to cross over and actually get denervated. And so there's an analysis of these patients as well. Next slide. In this trial, it's important to note that the mean number of medications that patients were on was 5 or greater, and patients actually had blood pressures in the 170 or above range in this trial. Largely, they were treated on reasonable medications, although the doses were not necessarily maximal in this trial. Next slide. And this was published in The Lancet. So here's the data that demonstrates a reduction, again, approximately 30/10. In this case, it was 32/12 in the denervation arm. In the control arm at 6 months, there was no change in blood pressure whatsoever. Next slide. Now, interestingly to note, as shown here at 6 months, there was actually a reduction in blood pressure in the control arm, and that's because patients were allowed to cross over and get denervated. And so again, the reduction was about 30, and this is actually reassuring to see, because it demonstrates that this is not just selection or otherwise. Patients actually, after having the procedure either up front or in the control arm at 6 months, had a reduction in blood pressure that was then sustained through the follow-up period. Next slide. And this data has been updated more recently, and the results are very consistent. Of note, importantly, renal function was stable. These trials excluded patients that had GFRs less than 45, and in this trial, actually, renal function was stable through the follow-up period, which was reassuring to make sure that you're not having any deleterious effects. As shown in those preclinical slides, there's this issue of char formation and otherwise, but again, there does not appear to be any untoward effects on the kidney itself. Next slide. Now, this has led to the design of the Simplicity Hypertension 3 trial. This is a study ongoing in the United States, actually suspending randomization at this point because the trial is full. Essentially, patients are screened. They then actually go for angiogram if they are eligible for screening with a blood pressure greater than 160 on 3 meds, and one of which is a diuretic. And at that point, they actually, in the lab, are randomized, and there's a sham arm. So there's 2-to-1 randomization, and if you're randomized to control, you have headphones, blinders on, and then the treating physicians are also blinded. So it's a double-blind study with a sham arm to ensure that this treatment is actually effective and safe. Next slide. And we'll await the results of the study. The hope is that these will be presented at ACC coming in 2014. So now, what about long-term effects, and what about the problems with this procedure? I mentioned there's a non-responsiveness rate of approximately non-responsiveness is approximately 20 to 30%. Now, what about other issues such as stenosis? So there have actually been some case reports, this is the first one, of a stenosis, and this is a patient who was successfully ablated and then represented with an increase in blood pressure, was found to have a stenosis which was safely stented at that point. Overall, it looks like the rate of this occurrence is exceedingly low, but the fact is it can happen, and so meticulous technique needs to be used, and it needs to be something that's followed over time. So this is, again, not just something that we can just go ahead and start doing in all kinds of patients who are typically young and otherwise okay, because there are downstream sequelae of this type of procedure. Next slide. Now, I also showed you before some OCT data. This is another OCT-related publication demonstrating some char formation that can occur at the site of a non-irrigated catheter. Whether this occurs with irrigated devices or otherwise is less clear. Either way, small amounts of char are likely to not affect renal function, as we know from those of us that do renal artery stenting procedures. But that having been said, this is again something to think about. Next slide. So what actually happens to renal perfusion? This is actually interesting data demonstrating that essentially you're doing what you think you're doing. By reducing sympathetic outflow to the kidney, you actually can decrease renal vascular resistance, and therefore perfusion-based parameters remain relatively unchanged. Next slide. And this is again a slide of looking at the renal resistive index after ablation. And in this procedure, the resistive index goes down. So what you're actually doing is truly affecting the efferent arteriole and clamping down on the circulation by things like A2 and the aldo axis as well. Next slide. Additionally, albuminuria, microalbuminuria in particular, tends to decrease. And this was data presented by Dr. Mahfoud and colleagues in hypertension, demonstrating that perhaps you can now start reversing the adverse effects of hypertension on the kidney. Now, whether this is actually realized over the long term requires further patience and more study, but again, pretty intriguing results from a procedure that was potentially deleterious to the kidney. You're actually showing benefits to kidney function in terms of microalbuminuria. Next slide. Now, the other question that comes up is, are you solely looking to treat blood pressure, or can you treat heart rate as well? And this is data presented by Yukina and colleagues at TCT demonstrating that actually in several patients, heart rate comes down. And if you were to actually look at the responsiveness rate and define it not just as a reduction in blood pressure by 10 percentage points or 10 millimeters of mercury, but instead to look at blood pressure reduction as well as heart rate reduction, one could actually affect a higher rate of responsiveness. So if you click through this to go to the next slide, you'll actually see there's a change in heart rate, change in blood pressure, but there's some patients that have one, some patients that have the other, some patients that have both. Next slide. So here's what you see. The non-responsiveness rate is approximately 17%. If you define it by blood pressure alone, go to the next slide. If you define it by blood pressure and heart rate, next slide. Next slide. You actually reduce this to about 7%. So let's just move on to the last portion of the talk, emerging data and other applications. Well, hypertension is obviously important, but it might just be the beginning with this technology, because denervation has actually been demonstrated to affect other disease states as well, in addition to hypertension. Next slide. And we know that sympathetic overactivity is seen in patients with diabetes, sleep apnea, and other disease states. This is just an example of glucose tolerance improvement. This is the change in fasting glucose after renal denervation compared to controls. There was a moderate increase, not something you use to treat diabetes per se, but you might find that your diabetic control gets better in patients that are successfully denervated who are eligible for the procedure. Next slide. Similarly, this is data with congestive heart failure. There are ongoing studies right now. This is preliminary data from 2 trials, one a small pilot study, another randomized study, demonstrating not only improvements in exercise capacity, but improvements in ejection fraction over time. This is being studied in a multi-center approach here in the United States, funded by the NIH, but also there are studies ongoing in the UK and other parts of the world examining the treatment of heart failure with renal denervation therapy. Next slide. Sleep apnea has also been something that's being studied. This is just early preliminary data demonstrating that you could reduce apnea-hypopnea index, at least have a trend to doing so in a trial of renal denervation compared to baseline. Next slide. And finally, interestingly, there's actually quality of life data demonstrating in a non-randomized fashion that patients' overall depression scores and mental health can potentially be improved. Now, again, this is something that could clearly be, as well as the other trials that are getting up and running from other companies like St. Jude, Boston, and the like. Clearly, hypertension alone, specifically resistant hypertension, is where this has the greatest promise, but we're also going to start seeing this being expanded to patients with less severe hypertension and perhaps even other medical problems that are modulated by the sympathetic nervous system. So thanks so much. Sorry for the whole web-based way of doing this, but I hope it came across clearly, and I welcome any questions at this point.
It was a very clear presentation. I thank you for it. I have just a couple of questions to ask. One, can you retreat someone, assuming they get a response and the response lasts, let's say, a year, and then they're coming back into for-drug hypertension? Can you retreat them?
I mean, definitely you can. The question is A, should we? and B, what's the evidence for doing it? And so right now, there are some patients in the Global Simplicity Registry. That's a registry that Medtronic's running globally in countries where the device is approved. There are some patients who are getting retreated, but we just don't know enough about it at this point in time. The other question that comes up is that if somebody's a non-responder, should you retreat those patients? And again, we just don't know enough about it right now. And I think the key thing is with these patients, especially as you start moving it to lower risk populations, the safety issues become important. And so right now it looks okay, but out to 20 years and beyond, are we going to really not have any stenosis? Are we not going to have any untoward effects of the procedure?
Right. We participated in some of the carotid sinus stimulation trial work. And what we found was that over time, people did respond as opposed to the placebo people. But unfortunately, it took more and more stimulation to keep them as responders to the point where the battery pack wouldn't last long enough to keep them going.
Yeah, I mean, I think that the issue of, basically auto-regulation or auto-correction is something that's important to consider. I mean, we don't even know simple things at present about, what the predictors of that are. And, is this more efficacious in patients that are already on beta blockers? Is it more efficacious in patients that have an elevated plasma renin activity? All those things right now we don't know. And so for many of us, I guess, who are in the field, we struggle with this disconnect, if you will, between the exuberant clinical data that comes out thus far, but also a basic understanding of what the pathophysiology is in patients that will and won't respond. And I think some of those studies need to be done. And certainly for countries like India, and I said this last year when I was in India, where you might have this device available and can do these studies. The field is really, really ripe for studies like this right now, looking at things like renin activity, looking at other things that are very difficult to measure in the context of a larger clinical trial.
Michelle, do you have any comments? Anyone from the audience have a question for? No questions. It was very well presented. We enjoyed it immensely, and it corresponds with other data that I've heard. I think there's a very exciting field, and I think that if the data continues to hold up, it will make a major contribution in many ways, probably ways we don't even understand yet.
Yeah, I completely concur. And again, thanks so much for the opportunity to present. It was a real pleasure.
Thank you. Very appreciate it.